Good evening. I have the privilege to invite our distinguished faculty this evening, Dr. V.K. Chopra and Dr. Nazir, distinguished faculty well established in the field for decades in India in the management of heart failure. Let me start with Dr. Chopra. Sir, could you please tell us what is the evidence behind the current medical therapy for advanced heart failure in the context of Indian population, sir?
So, the medical therapy in Indian patients is pretty much the same as it is in any other part of the world. We have progressed a lot in our understanding of heart failure, starting from pump failure and forward failure and backward failure. And today we realize that neurohormonal activation plays a very significant part in heart failure. Whenever there is a heart failure, there is an activation of neurohormonal systems, which initially are adaptive responses. But in course of time, they become maladaptive, and that leads on to remodeling and dilatation of the heart and all the adverse effects. It followed therefore that the benefit would accrue by taking care of those neurohormonal activations, and this is indeed what has happened. So that when there is a sympathetic activation, we know that beta blockers have done a great job in reducing cardiovascular endpoints. With RAS activation, when all the adverse effects are there, we know that angiotensin receptor blockers, ACE inhibitors and aldosterone antagonists have done a wonderful job in reducing the cardiovascular endpoints. There was always a third arm called natriuretic peptides, which had all the beneficial effects. But the problem was that nobody was able to harness it for management of chronic heart failure, for the reason that it had a very short half-life and had to be given intravenously.
Sure.
So then people thought that if we can't use it for chronic heart failure, why not give a drug which suppresses the enzyme which is responsible for its breakdown. And that is how this new molecule sacubitril valsartan was developed,
Sure.
which when ingested breaks down into two components. One is valsartan, which is an approved drug for heart failure, being an angiotensin receptor blocker, and sacubitril, which is a neprilysin inhibitor responsible for the breakdown for natriuretic peptides.
Sure.
Why valsartan also had to be added? Because this also prevents the breakdown of angiotensin 1 and angiotensin 2. So you had to have angiotensin receptor blockers so that the beneficial effects of natriuretic peptides don't get countered.
Sure.
So today, after the landmark paradigm trial, which was stopped early, ARNI has become a mainstay of the treatment. And after the initial hesitation, because it was only a single trial based on which it got class 1 recommendations, gradually realization has dawned with experience that it's a wonderful drug and its utilization has made a lot of difference.
Sure.
Fortunately, in our country, the price of ARNI is much less than what it is in the Western countries. So there's a greater acceptability. And we know that in our patients also, it makes a wonderful difference in terms of reducing mortality and morbidity.
Sure. So in a stable patient, let's say with class 3 heart failure managed by a general physician, would you continue to recommend that the ACE inhibitors can be safely transitioned to an ARNI as long as the patient is stable, since that's what the current evidence would be?
Okay, so first of all, let me tell you, I want to clarify something. There is nothing called a stable heart failure. This was seen in meta-analysis of paradigm and some other studies. Then when class 2 patients who are hardly symptomatic, they had never been to the hospital once in the last 1 year. When they were followed up, there was a significant mortality in these patients also. In fact, if you see Indian context, how were Indian patients different? Number one, they were younger, which we know. There were more females, which is an unfortunate gender bias. Their heart rates were higher in paradigm, which is probably because of underuse of beta blockers.
Sure.
And fourth is, a lot of them were in class 2. Now, if you analyze paradigm results, there was nearly 33% incidence of sudden cardiac death. So paradigm trial showed us that ARNI reduces not only progressive heart failure, but also has a significant beneficial effect in reducing sudden cardiac death. And remember, class 3 and 4 patients are going to die of progressive heart failure, while class 2 patients are going to have a sudden cardiac arrest. They'll never come back to you.
Sure.
So therefore, the weight of the evidence is that it is useful. It is a slightly expensive drug,
Sure.
but if a person can afford it, then it still gives you overwhelming benefit in reducing sudden cardiac death.
Sure.
So the point is, there is nothing called stable heart failure.
Sure.
In fact, in the paradigm trial,
Yes.
72% of the patients were class 2, 23% were class 3. and the rest were class 4. So, majority of the patients were of class 2.
Sure.
The advantage of ARNI versus ACE inhibitors or ARBs is you are getting additional 20% benefit versus ARBs and this thing. So, what in fact you are getting about 20% reduction in mortality, with ARNI you are getting about 40% benefit in mortality. So, that is the advantage of ARNI, and given a choice whether you will use ACE inhibitor, ARBs or ARNI, the first choice will be ARNI.
Okay. So, cardiomyopathies is a substantial portion of our overall heart failure population, including children and adolescents and of course adults, which could be non-ischemic. So, Dr. Nazir, could you please tell us what are the newer therapies or drugs which can be used or which have shown some benefit in cardiomyopathies leading to heart failure?
Yeah, as he had said, ACE inhibitors, ARBs, MRAs, beta blockers, they form the basic therapy.
Sure.
But now with the newer molecules which are in pipeline, there are certain specific molecules for certain cardiomyopathies. For example, if somebody has got amyloidosis, proved amyloidosis, there is a drug called tafamidis,
Sure.
which is very useful in the treatment of amyloidosis, and this is definitely going to bring down the mortality in amyloidosis. This particular molecule prevents the breakdown of tetramers into monomers, which gets deposited in the heart and various organs. The other drugs or other molecules which are in the pipeline are the ones which act on the myosin. The one which is used is omecaptive, which is in the trial now. In the trial, this omecaptive is the molecule which stimulates the actin-myosin coupling, and it has shown in the preliminary data that improves the ejection fraction, reduces the end-diastolic volume of the ventricle, and hence this omecaptive molecule is in the galactic heart failure trial. The other molecule which has been used in hypertrophic cardiomyopathy is mavacaptan. This particular molecule acts exactly opposite way. It reduces the contraction of myosin. In preliminary data of about 21 patients or so, the gradient across LVOT have come down from 111 to 19, that is significant, and hence there is a larger trial going on which is Explorer Hyper HCM trial, which will explore the utility of these drugs.
Dr. Chopra, coming back to the burden of heart failure in India, in the last decade, I guess in terms of diagnostics and giving some prognostication, biomarkers is a hot field. So, please tell us what is the utility of BNP and NT-proBNP in the face of the use of ARNIs, and how best we can use it as far as...
First of all, if you are using ARNI, you will not be measuring BNP, because by its very mechanism of action,
Increases
it raises BNP levels tremendously. So, if somebody is on ARNI and you want to see what is the progress, or you want to monitor it, the test is going to NT proBNP.
Sure.
Now, NT proBNP is a very sensitive marker for heart failure. It has a longer half-life than BNP, and therefore, it's likely to give you a little bit more stable results. Whether a therapy should be guided by biomarkers or not has been a debatable question. I think the maximum use of NT-proBNP or such like comes when the patient first comes to emergency.
Sure.
This person has a chronic obstructive lung disease, it may be anemia or heart failure, and you are not very sure whether dominant etiology is respiratory disease or a heart failure. So, there is an evidence that natriuretic peptides help in helping you decide. Not always, there are other conditions which go up, in which they go up, and we have to remember that with age it rises, in renal failure it goes up, in atrial fibrillation natriuretic peptide levels are high. So, all those factors have to be kept into account.
In fact, we did a study in children with acute decompensated heart failure, and we published in PCCM. We looked at all the new onset in children with acute decompensated heart failure. Most of them were dilated cardiomyopathies. As long as we showed an exponential decrease in NT-proBNP, they had much higher transplant-free survival as opposed to less decrease in NT-proBNP, and that's what now we are translating it to adult congenital heart disease with heart failure as well. So,
but there have been trials where the therapy, when it was modulated with natriuretic peptides versus where it was not, there was equivalent results.
Sure.
But otherwise it stands to reason. Somebody comes with a very high natriuretic peptide levels, and at the time of discharge there is a significant drop, you are going to have a better prognosis.
Sure.
Persistence of high anti-pro-BNP also carries a worse prognosis, so that we know. It just is just a marker that the heart disease is more severe.
Sure.
Maybe you need to step up your therapies a little bit more, maybe do something different.
Sure.
But then there would be conditions where whatever you do, it still remains high.
Sure. So, Dr. Nazir, ICD and CRTD have their own specific role in the management of heart failure. Would you think we have enough utilization of these therapies in the specific subset of patients in heart failure?
Yes, see, today we are talking of how to reduce the mortality in patients with heart failure. Another number or two, there are 2 or 3 issues. First of all, we are not using optimal medical line of treatment. That means we are not using all the drugs, we are not using in appropriate dosage, and we are not using for a longer time. That is one. After that, the benefit is of ICD, which prevents sudden death, and the role of CRTD. I think in India, because of the cost issue, the utility of ICDs and CRTs is much less. As you know, if somebody has got congestive cardiac failure, if he has got left bundle branch pattern, and if his QRS duration is more than 150 milliseconds, he is going to definitely get benefited with CRT if the ejection fraction is less than 35. It's not only in class 2, in class 3 and class 4, but even class 1. If you have got this type of picture, they have shown the benefit of CRT. In fact, the number needed to treat to get benefit of mortality is just 20 or so, same as what you need in beta blocker versus ARBs or ACB, where you require a slightly higher number.
But as you said, the key would be to adhere to the proper dosing and use of beta blockers and ARNIs or AC inhibitors.
Yeah, and in addition, you have to have, so anybody with ejection fraction less than 35, he is prone to sudden death, and lesser the ejection, there are 3 components of it. More severe the reduction in LV ejection fraction, more chances of having complication of sudden death. The etiology of it, dilated cardiomyopathy or ischemic versus non-ischemic cardiomyopathy. In fact, there was a recently the controversial trial was the Danish trial. The Danish trial was a non-ischemic cardiomyopathy, where they showed that the use of ICD did not help. But 50% of these patients were on CRT. And the Danish trial, the one what needs in future is use of magnetic resonance imaging. So, those patients of non-ischemic cardiomyopathy, if they show a scarring on left ventricle on MRI, they are the ones who are definitely going to get benefit of ICDs. So, ICDs, any patient ischemic cardiomyopathy, ejection fraction less than 35 is indicated. Because of cost and because of lack of probably the knowledge to everyone, we are not utilizing ICDs in CRT as they should be used.
Danish study has been criticized also very extensively. First of all, as Dr. Nazir has already said, that is one point. And second thing is that more and more people believe that in a relatively younger people, ICD is going to give greater benefit. You know, if somebody is already very elderly,
Fibrosis
almost in a extensive heart disease, terminal condition, there are so many other comorbid conditions which are going to take a person away. So, in a relatively younger person, it has a role. And then MRI, the amount of fibrosis which is present, that indicates, the likelihood of arrhythmias even in non-dilated even in non-ischemic cardiomyopathy. So, MRI again is very useful in deciding who should be getting this kind of a thing.
In fact,
right bundle branch block has been, debatable point. If it is more than 160 milliseconds, people vary between class 2A and class 2B. But in left bundle branch block, more than 130 milliseconds becomes a class 1 indication. In class 3, class 2 and in ambulant class 4.
See, MRI is going to help you in other ways also. Even patient with hypertrophic cardiomyopathy, his ejection fraction need not be less than 35%, but if his MRI shows that there is a scarring and he is high risk for sudden death, he requires ICD. Patient with sarcoidosis, if they show a lot of fibrosis, then you don't look for the ejection fraction of 35. Then even with a higher ejection fraction, you will require ICD. So, MRI is the one investigation which is going to definitely improve our sub-selection or criteria for use of ICD.
Dr. Chopra, please tell us about the newer molecules, like for example in diabetic cardiomyopathy, the GL2 antagonists or...
So I think the hot news, as you must have read a few days back,
Sure.
is the DAPA-HF trial, which has turned out to be positive. So I was national lead for that and for Paragon, etc.
Can you please elaborate on the study design and like what
So in DAPA-HF and in other studies also, so, you know, there are 4 SGLT2 trials which were in our country. One is DAPA-HF, then second is DAPA-CKD, in which they took dapagliflozin in patients of chronic kidney disease. The CKD trial is still on. Then there is Emperor reduced and Emperor preserved, in which empagliflozin is being used in reduced and preserved ejection fraction. And fourth trial was sotagliflozin in heart failure. Now sotagliflozin, they were using it in heart failure, but also trying to show benefit in renal functions between creatinine clearance of 15 to 30. Now that's, you know, the preliminary results are not very encouraging, and therefore probably Sanofi is not very interested in continuing that trial.
Sure.
They have handed it back, the molecule back to the original researchers. Now DAPA-HF, which has been top line results have come, it's going to be presented on the 1st. That is positive.
Okay.
You know, more than that I cannot tell
Sure,
you, although
sure,
I know the results, but
Sure.
I cannot tell you. There's a non-disclosure.
So we'll be looking for the publication.
So on 1st of September, it's going to be presented as an
Study
as a
results will be at
late-breaking
the-
trial in ESC in Paris. By their mechanism of action, you know, we know that SGLT2 inhibitors basically prevent resorption of glucose from the tubules, and simultaneously there is salt loss, water loss, and so on
Osmotic
and so
diuresis.
forth. But surely these were not the only mechanisms involved. If they were, you would do the same thing with anti-diabetic drugs and diuretics.
Sure.
With diuretics, if you use, there is a tachycardia. With the SGLT2 inhibitors, there is no tachycardia. The other theories were that there is a greater utilization of fatty acids in myocardial metabolism, which is more energy efficient. Uric acid levels come down, and so on and so forth. So I think we are still working out, or they are still trying to figure out how it works. It works.
Sure.
Ultimately, that's what matters. And if it shows a significant reduction in mortality, great. So how DAPA-HF trial was done was, they took nearly 50% of patients who were diabetic and 50% who were non-diabetics.
Sure.
Because by its mechanism of action, it does not cause hypoglycemia. So it was being tried as a pure heart failure drug. So if this turns out to be positive, it is positive. If the detailed results also indicate the same thing, is going to be a great
Game
new
changer.
drug in our armamentarium of dealing with these patients.
Now, heart transplant would be the ultimate therapy for a failing heart, as we know, across the age spectrum. LVAD has an equally important role in the treatment of advanced heart failure. As of now, at least in the pediatric age group, LVAD has not been FDA approved as a destination therapy. If you have an adult with advanced heart failure, would you consider an LVAD as a destination therapy versus listing him for heart transplant, given the equal choice you have?
Yes, in elderly patients, yes, those patients who have got a comorbidities, they are elderly, more than 65 years of age, and there are other certain indications.
Sure.
Definitely the newer LVADs, for example, in Momentum trial,
The third generation.
the HeartMate 3 is which is magnetically elevated device, and it's a centrifugal axial flow, and this has shown over 2 years the survival of 77.9% versus HeartMate 2, which was 56.7% or so, and that 77.7% heart transplant also is
Almost
somewhere
close.
around 80% or so. So that is something which is very, very positive about it. So HeartMate 3 is something which is going to make a lot of difference in future.
The issue in our country is the cost.
Cost.
You
It's
know,
the cost.
It
It's
is so
3 times
expensive
cost than the heart
than the heart
transplant.
transplant.
Sure.
You know,
So that the
that's a
cost is the
major
only
major
thing
problem.
which is, of course, the infection, the other things,
we are a hot
line
country, you know,
infection
people
and
sweat and-
care of the particular person. But since there is a shortage of hearts, availability of hearts in India, I think these LVADs are going to be useful if the price is not the consideration.
So, as a take-home message for our colleagues, as well as translating it to general physicians in the community, since you worked for decades in the field of heart failure, what is your message to overall to decrease the mortality in an adult or in anyone with advanced heart failure?
So
now, how to adhere to the guidelines and what are the basics we need to follow?
So I would say it starts right from the beginning. When a patient comes to you, we have to start from stage 1 heart failure. That means if a person has hypertension, diabetes, etc., these
at
are
risk
the ones
for heart failure.
at risk for heart failure.
Sure.
So they are the ones who are going to get later on.
Yes.
So appropriate and scrupulous control of risk factors, stopping smoking, regular exercise, leading healthy lifestyle. Everybody knows it.
Correct.
But hardly very few people follow it.
Correct.
Subsequently, it is not to be complacent. If you have put somebody on therapy for heart failure, then you need to step up the doses either to guideline mandated treatment or to the maximally tolerated dose.
Correct.
Very often it happens a person is on a small dose of ACE inhibitors, they come, they said I am fine, so you also continue. That is therapeutic inertia.
And then you find out at an advanced stage.
And we know that it later on leads on to worse outcomes. Third very important thing is patient education. In a busy clinic, we people do not spend enough time in educating patients about diet, vaccinations, activity, concurrent respiratory infections, looking after other risk factors. These are extremely important factors. So education of patients, probably I think here the role of heart failure nurses in heart failure clinics is extremely important.
Sure.
They can educate the patients, they can solve their doubts. If a patient is discharged after acute decompensated heart failure, they can call them up, find out what they are doing. The mortality and morbidity is highest in the first 1 month or so after discharge from the hospital. So a close follow-up, even on telephone, it helps a lot. Sure. So I think these are some of the adherence to guidelines basically.
Sure. As a corollary to what Dr. Chopra said, we have an app to manage advanced heart failure at our center at NH. We have about 800 patients enrolled in that app as far as adherence to the medications and communication with the parents, and that's mostly driven by the heart failure nurses. So I think that would be the very key. So Dr. Nazir, your other closing points to this discussion?
Early detection, proper dosage of the medications and adherence to the medications, regular follow-ups, and appropriate use of ICTs and CRTs. That's the thing that will prevent a lot of investment in left ventricular assist device and waiting for heart transplant.
Sure. Thank you, gentlemen. It was so nice talking to you.
Thank you.
Thank you.